of which 36 are federal government run because those states decided they didn't want to put all the work into it, create their own software and host it. And then we have 14 states, among it California, Undercovered California, that has its own health insurance exchange, where you, October 2nd, can basically enroll if you don't have insurance or if you have someone who needs it. So what happened there on Friday, it was reported in the New York Times, is that the government software has glitches. So when you're trying to figure out how much you need to pay, it just won't give you an answer. So it won't impact us because we hopefully don't have that software glitch. So that was one development on Friday. So it's a very suspenseful saga in a topic that normally feels like a root canal. Nobody really wants to deal with it. But when it happens, you need to. And October 2nd, you have a chance to either decide your own fate or have your employer suggest what you should do. It maybe Joyce will dive into that later. The other one was on Saturday. The Republicans, of course, are saying it's getting closer to the date. We want to, thwart everything, and they are staging a little revolt, or we call it awareness campaign, and where a lot of good misinformation is going to come your way. So that's something to watch out for. And then the other development was this morning, where you have an insurer that will offer something via that health insurance exchange, let's say Covered California, but he's decided, if I offer this premium, it's a lower price, I'm going to give this patient a very small network of providers. So what's happening is you will get an offer, but your network that used to be 36,000 providers has dwindled down to 15 because the insurer decided it's going to be cheaper for us. So caveat emptor, and we will listen more. Lynn will have some insights, and I'm sure Michele is going to offer from the hospital perspective, or not. Okay, so that would be the quick overview of what happened this weekend. Now, what we are, of course, keen to do here is to answer your questions. So I don't want to be babbling at you, tossing numbers around, but rather we want to know who is in the audience, what are you interested in? So if you guys could give us a show of hands, who is self-employed looking for insurance? Okay. Who is husband or partner is employed, therefore covered under employer-funded insurance? Okay. And who's here just to learn more about it because they want to decide their own fate? Okay. Cool.
I'm also here for a slightly different reason. I'm under COBRA right now. My job just ended.
And we actually, you know what? Yeah, I'm sorry. Before I go further, so the one pager is just that teaser, but COBRA is covered, and I probably won't cover it here, is covered in that primer. At least you have a few links you can bounce off to get to the details. So COBRA is kind of tricky because it might be, you might be limited with what your employer offered you, but on the new health insurance exchange Covered California, you might get better options at a lower price.
Yeah.
So these are the things that COBRA folks will have to consider, and that's in the primer. So we can tackle that later.
And I think I'd like to make the transition anyways, because right now I'm dependent on my employer, and it's a consultant that keeps changing. And so,
okay.
I assign
Sounds
the
like you
hands
should
my
take
coverage
the rudder
ends.
and
Sounds
drive
like
your
I should
own.
just
Yeah.
go. Yeah.
Okay, so the other one I had is, I've already been receiving flyers. So I'm getting, I got this one last week. We see full page ads by Aetna. Aetna, I think, is not making an offering in California. We're going to make it all easier, it's all cheaper, and it's more intelligent, right? So
it's not California.
It's not in California, yeah, they're not in California. And interestingly, I actually, in that sheet that you have in front of you, there is an astounding number that's circulating. So $86 million are being invested in advertising. So 86 million are going towards advertising health insurance exchange, Covered California, to the 5.6 million Californian uninsured folks that they're trying to bring into the fold by 2014. Now, think about it. 86 million divided by 5.6. Now, that's $15,500 per person. Now, I suggested marketplace.org this afternoon or this morning. I sent it to Kai Risdell. Think about it. Why don't they pay for the insurance for those people for the first year and get them all primed to wanting to have those benefits, and then maybe ease their way into for the next year that they can continue paying for a different plan or the same plan. Just a suggestion. I'm hoping they're going to reply or air it. I'm really curious. To me, it makes no sense. The numbers make no sense. Okay, so we established there are folks looking. Who is currently satisfied with the health insurance they have? You? Okay. and who is just disgruntled and had it and just cannot wait till October 2nd to roll around? You are, okay, cool. So this gives us and the panelists a better understanding of, you know, what you're looking for, and I'm going to guide it with a few questions, and it's not like I'm the only one talking and asking questions. So if you have something where you're feeling I am burning, it's an intimate setting, and I'm grateful to you guys to come out on a Monday because I know this is really tough and in a faraway location, so I'm grateful you're here. So I'd love a brief intro of each of you and how the Obamacare or the ACA has impacted you and your job. If we could start with that, and maybe Lynn, you want to take it, introduce yourself, impact of ACA.
My name is Lynn Caffrey, and I run a small brokerage. I've been a broker for about 30 years. I've been all into the business for about 40 years. And this is the biggest single thing that's ever happened in our industry because virtually everybody is affected, all small groups and all individuals. On October 1st, we start re-enrolling every single individual client we have, which is at least 300 of them. And every one of our small groups, which is about 120 of them, have to decide something. So it's a huge impact for us. We are still learning. We only just took the training on Friday to learn how to use the Covered California Exchange. And I have probably as many questions as you're going to come up with. So when I talk to you today, it will be to the extent of my knowledge, but it's a moving target.
So again, my name is Michele Van Zuiden. I'm the Executive Director of Women's Health here at El Camino Hospital. We have 2 locations, one in Mountain View and also one in Los Gatos. And from my perspective of women's health, just in general, and an advocate for that, some of the positive things about the Affordable Care Act is that it does offer preventative services specifically for women. Things like mammographies are going to be covered, so no out-of-pocket dollars for that. And then also maternity care will be required for all insurance companies. And right now that is not the case. In fact, many insurers do not cover maternity services. So if we look at sort of overall women's health, it's very beneficial. If I put on my employer hat, we have about 4,500 employees here with El Camino. We aren't changing our health plans at all. We have a very unionized environment, and there's a shortage of healthcare professionals, and therefore we make sure that we have a rich benefit package for our employees, so we don't see any change in regards to that. And I'll share a little more about, it's going to be a big impact, more of a negative impact actually from a financial sense for most hospitals that are independent, not-for-profit hospitals, and I'll go into a little bit more of that later. Even though you think more people will be insured, we actually will be paid at very low rates because they're government programs. So.
Joyce is still digesting the
I'm
information.
learning as I'm listening. So I'm representing the employer, and I'm representing this small employer. My company has about 250 employees. 50% of them are in Germany and Denmark, and the other 50% are in the US. And of them, we have about 90 in California. So as we're going into our benefits renegotiation renewal this year, it's been a fascinating ride. And I have a fabulous broker in my back pocket, so I'm really interested to hear what you have to say, Lynn, too, because if it wasn't for her to be my filter, it's, as you were saying, Nicole, you get a lot of information that comes at you from all sides, and I just pick up the phone and say to her, what do I need to listen to? You know, what's my filter? And she's been very good about coaching me through that. And then my background, and so I have full sympathy for the people that are still learning this. My background, I started off in human resources 20-some years ago in benefits, and I started at the grassroots when everything was paper and it was not online, and we were self-insured and we were doing trust administration, and I was living, eating, and breathing kind of all that back stuff that went along with benefits administration. And I worked for Georgetown University, so it was a hospital as well, and so that's where I started. And I have a strong benefits background, and I'm still very confused right now. So I'm willing to share what I know, but
LumaSense Technology.
my company's LumaSense Technologies. I didn't mention it. Thank you.
I don't know. So,
Well, it's finally happening. After years of drama on Capitol Hill, A Supreme Court case, a presidential election, and a Mayan apocalypse that could have stopped it dead in its tracks, but didn't? The marquee elements of the Affordable Care Act, sometimes called Obamacare, are about to kick in, and big changes are coming to health insurance in 2014. In the next few minutes, you'll get a pretty good lay of the land by once again watching your fellow Americans, the U-Tunes, find their way through the system. There are 4 main ways nearly all of us will experience health care once the health reform law goes fully into effect. About half of us will get insurance through our jobs, just like today. About a third will get covered by the government through Medicare and Medicaid. About 1 in 10 will buy insurance themselves. And unfortunately, another 30 million of us or so, just under 1 in 10, still may not have coverage at all. But let's begin in the workplace. Many Americans are already covered by their employers, and for them, not a whole lot will change. There will be some new advantages, though, like caps on how much you have to pay out of pocket, and free preventative care. The bigger changes are coming for those who work for larger companies but aren't covered now. That's because the government is going to require companies with 50 or more employees to cover full-time workers or pay a penalty. So, more workers may find themselves covered. Smaller employers won't face the same penalties for refusing to buy insurance, but they'll be encouraged to do so. The government will be setting up special marketplaces to make it easier for small employers to take the plunge. Some will be offered temporary tax breaks if they do, and unlike now, insurers can't inflate prices if some employees are sick. So, many of us will be getting covered at work. A lot of us will be covered with help from the government, just like today. Not much will change for seniors on Medicare. The law has already started helping with prescription drugs and better preventative care, and that will continue. Medicaid, on the other hand, is expanding to cover more of us, especially poor adults, many of whom aren't eligible today. If your income is low, Medicaid will cover you, most likely in a private insurance plan. But there's a catch. The Supreme Court ruled that governors and legislatures of each state should decide whether or not to be part of expanding Medicaid. In states that get on board, the feds will cover almost all the cost. But for those who don't, you may be left with the same options you have today if you're poor. So you'll want to check out your state's decision if you think you might qualify for Medicaid. Even with employer coverage and the expansion of Medicaid, a lot of us will still be left out. For those not covered or who find their work coverage too expensive, a new way to buy insurance on our own will be popping up everywhere. They're called health insurance marketplaces, though they may have a fancier name than that in your state. The health insurance marketplace is like a virtual insurance mega mall. Here you'll find private insurers competing for your business, and you'll be able to pick out how much coverage you want and how much you want to pay for it. From cheaper, high-deductible bronze plans to more expensive platinum plans. Still, all plans will cover a comprehensive set of services like hospital and doctor visits, maternity care, mental health care, and drugs. Most everything any of us need, at least when it comes to medical care. As with Medicaid, not all governors are on board to set up these marketplaces, but the feds will open their own in those states, and so you probably won't notice much of a difference. One big advantage of buying insurance through these new marketplaces is that the federal government will provide most people with a tax credit to make insurance more affordable if you don't have any other options and your income is below a certain level. In fact, most people buying on their own will be eligible for a tax credit and won't have to pay the whole premium themselves. And the marketplaces will make sure that insurance companies operate fairly under strict rules. They'll have to offer everyone insurance, even if they're sick. And they won't be able to charge more for pre-existing conditions. Unlike today, men and women will pay the same price. And prices for older people will come down, while young people will pay more. To keep costs down for young people, though, they'll be able to stay on their parents' plans until 26 and buy low-budget catastrophic plans until they're 30. Of course, all these changes still don't mean insurance will come cheap. Most people buying their own coverage will end up paying less with the new health insurance tax credits. But some people will have to pay more, even though many of them will be getting better and more secure insurance. So let's be realistic. Not everyone's going to run out and buy insurance. Some might say, hold on a minute. If I can't be turned down or charged more, why not just wait until I get sick or injured to buy insurance at all? Well, first, you can only get coverage during special enrollment periods. So if you snooze, you may lose. And second, thanks to something called the individual mandate, if you're not insured, you pay a fine, making this option seem not nearly so clever. Still, if you really can't afford to buy in and can't get insurance anywhere else, the government will waive the penalty, so don't panic. By now, you've probably noticed a lot more people will be getting a lot more coverage. Where will the money to pay for that come from? Taxes. Many of them targeted at the health industry itself, even canning services. Yes, individuals will pay too, mostly the wealthiest Americans, who will be paying more into Medicare. Also, hospitals and insurance companies participating in Medicare will get paid somewhat less. Not painless, but somebody's got to pay. So, as Americans prepare for 2014, how will you be covered? How would you like to be? Now's the time to figure it out and get on the path to setting yourself up for the best insurance at the best price. After all, who wouldn't want that?
There we go. So we have an overview. I hope it was entertaining, probably more entertaining than you talking heads. There's a couple more numbers just to kind of ground also the expenses. So we saw that on a total healthcare cost that we're spending in the U.S. right now is there's 3 trillion, 2.7 is the number that everyone is settling on. So 2.7 trillion, this is not billion, trillion. And for each person it is $8,500, multiply that by 3 and you get closer to that number. For a family of 4, the typical healthcare costs around $22,000. Of those 22,000, 13,000 are paid by the employer, and 9 are for you, out of pocket, out of pocket as well as premium. That's sort of how it is kind of split up. And then the other issue, maybe we can talk about later, and I think I'm not going to go there yet. Maybe we can talk later about the issue why people are confused about healthcare or don't want to deal. It is most people don't understand their insurance. They don't understand the pricing. There's no real transparency in the pricing, although in California there is a law that they need to disclose the prices, and there's actually a website, which is also in the primer, where you can link to where you can compare costs, or at least the costs that they submitted. I also heard on marketplace.org, a great radio station, LA, you can actually negotiate your prices. And maybe we could talk about that later, not that you want that. So these are all information in here, and if you wonder what the healthcare cost drivers are, cancer, heart disease, diabetes, chronic. Most of them are preventable. And this is, if we can touch on it later too, that's why employers are really keen on getting wellness programs going, because they're understanding too, if I have a healthy workforce, I need to pay less. They don't need to go to the doctor as much. It's a win-win situation, and maybe Michele, if we have time, if you can offer, if you guys are doing wellness programs with local employers and all that. So these are just a few things. It's all in here if you want to reference back and forth. So do you want to start with the employer perspective first, or do you want to dive into the self-insured? Because I have tons of questions for both. I'm going to let you lead my questions. So what's the preference?
How about self-insured?
Self-insured. Okay, so self-insured. I'm taking it to Lynn. So, and if you want, a quick entry is, so my husband started a startup, 4 founders. They're all average age around 46, 48. They're all used to PPOs, and they ended up going to an insurance broker outfit that is probably similar to you, which is in the building that they're at. So Winchester, I don't even know what the address is in San Jose, has nothing but startups in it. So there's one insurance guy in there who owns the building, because all these startups talk to one another and nobody wants to deal, and my husband ended up with the healthcare stuff. So lining venture capital up is one thing, but healthcare was the other. And Why did they do it? Well, first of all, they're 46, they have family, and they don't want to worry about it, was one answer he gave me. But he also said, in order to get engineers, I need to offer the full package. And I think that's why most people, most employers offer healthcare benefits, let's face it. They want to attract and retain good people. And you heard also smaller companies don't need to offer anything, but a lot of good smaller companies who really care to attract and retain the right people will offer it, and they can do that via shop, and we'll talk about that later. So Lynn, we've covered audience, but can I ask you one question now? With seeing all this, have you noticed that you're changing your lifestyle? Are you trying to live more healthy because you're kind of worried about, am I covered? Will it fall under that? Have you made any lifestyle changes? None? Okay, all right. So, Lynn, you had just alluded, I think a moment ago, that you have a lot of changes that you're navigating through. Could you share maybe a typical individual that comes to you and how you help that person, and where do you start? What are the first steps?
Well, until we started with the Affordable Care Act, a typical person would come to me and I would have to find out if they were insurable. So very frequently, the best thing about the Affordable Care Act is that everybody's going to be approved for coverage. Nobody can be rejected. Pre-existing conditions cannot be unpaid. So, and in my opinion, that could have been handled a lot more simply than the complexity of this plan, but you know, it's falling among it. So when a person, so we get phone calls probably 5-6 a day from individuals who need insurance. And they often have COBRA as an option, but COBRA is typically pretty expensive. So I have to determine if they're insurable, and sometimes insurance companies are fussier than other kinds, and different companies are fussier than other companies. And so what we do is we say, I think you might have trouble with that, so maybe I'll do a pre-underwriting review on you and see what happens. And so I do that with a couple of companies, or I just offer them quotes and we take it to, and we submit applications and see what happens. So it's my responsibility to analyze the person, to see what their choices are. I might recommend that, I will always recommend that they keep the COBRA options open until they're safely covered by a carrier. Something people often don't know is that you can continue your COBRA for 63 days open, and then you can commit but not pay for another 45 days. So you really have 3.5 months in there in which to get other coverage. So I try to work with people with all of their options to figure out what works best for them. If they're really stuck between a rock and a hard place, I'll find them a guarantee issue program. But that's all going to go out the window now, and I can find them anything that's available.
So can I put on the following question, because we heard in the video that most of us will benefit from tax subsidies. So would a person, and I want to ground this real quick for you. So individual earning up to $46,000 a year. So this is an individual, right? Mm-hmm. And couples making up to $62,000 are eligible for subsidies to buy insurance. So would they come to you to discuss the tax subsidy question, or do I need now a tax accountant too, who's going to help me with my healthcare choice? So if I make a choice with you, do I need to turn around and walk to my accountant?
No, you really don't. It's all on the website. So the way that it works is that if you are between 138% and 400% of the federal poverty level, you will be eligible for some kind of subsidy. And there's actually charts, and they're on the Covered California website, that describe those amounts. So a family of 4 can earn up to $94,000 a year and still be eligible for some kind of a subsidy. And the subsidies are not anything that you have to request to get that money back. It's actually deducted from your premium each month. And if you are in a category where you're below 138%, then you're Medicaid eligible, but you use the same sign-up online to sign up for that as well.
And I don't know if you guys have seen it, there were actually articles where they're saying that Costco is going to offer health insurance. Let's talk about that. So I don't know how you feel, I just don't feel comfortable buying health insurance from Costco. Can we maybe, what's the latest on that one?
Fortunately, that's not happening here. I would always recommend using the help of a broker, somebody who knows what they're doing. There's just too much complexity out there. It's like you wouldn't, if you could pay your taxes by yourself, you would, but using an accountant is usually a better idea. And, if you're going to go to court and defend yourself, not a good idea. It's a better idea to use somebody who knows what they're doing. And the great news about using an insurance broker is they don't charge anything. So it, unlike any other professional, so it's really, it works out well to use a professional.
So if we're all running to Lynn, she might be overwhelmed. Now, if you go to Covered California, there's actually a link, and I think we looked at that, right?
Right.
Where you can find accredited
Yeah.
consultants. So
Right.
instead of, depending like my husband, because it was easier, saying, hey, what do you use? No, I'll use the same guy. You can actually go to the site and then, look at the various profiles, see who is close, because the one thing I notice, if I have questions, I feel more comfortable looking that person in the eyeball, go to the office, have a personal discussion, and within 10 minutes it's done, right? So you can go to the site and you negotiate and navigate and find someone locally who is accredited. And they have to be, if they want to be in good business standing, it would behoove them to do that. So that would be, I
Could you
think,
repeat what site that is?
oh, it's Covered California. It's all
It's
Covered California.
coveredca.actually.com.
Yeah, and it's all in the primer. Yeah.
coveredca.com.
It's all in the primer. Yes, Bettina.
One question, because you mentioned preconditioning, so it's everything, if someone has
Doesn't matter.
preconditions, it doesn't matter. But is the rate the same as everyone else? So there's no...
No health questions at all.
Okay.
But it's based on age, isn't it?
It is based on age, it is based on zip code, and every single member of your family is put in there to come up with that rate.
But it's not that, they have internal different prices for...
No, not at all. Not at all. Yeah.
So any more questions? Because, it's your floor.
I have a question. I took the early retirement from my company, and they offered 2 years of insurance at the corporate rate, and the insurance is going to expire August 31st, 2014. So I noticed that the enrollment is October to March.
Right.
So
Right.
can you make any recommendations or suggestions should I cancel my employee insurance and start beginning of 2014, January 1st?
You can check it to see how it compares to your employer plan, both in cost to you and in benefits. But what you're going to experience in, what month did you say?
August.
August is considered a qualifying event. So you're losing your other coverage and you don't have to wait for open enrollment to join the plan. You can join it when you lose your other coverage.
Oh, okay.
And that's true for anybody who leaves a job, or somebody, a child who turns 26, or someone who in any way loses their other coverage. They can join during the year.
So, since we're in, did you just raise your hand?
Yeah, but go ahead, I can.
No, go for it.
Well, I'm on Aetna, and as you know, they're leaving California. So is the health coverage, I'm just not sure if it'd be best for me to start something for January, or is any of this starting now when October
No,
begins?
nothing's starting now.
Okay.
You can sign up now, and you might as well start learning about it early, but it's all going to be effective January 1, and thereafter, up until the latest, I think, is May 1, based on when you enroll.
So Lynn, do you think right now, because of the Republicans are trying to create a lot of misinformation, that if nobody signs up because they're wanting to wait out what's happening on the Hill, it could implode potentially, right, if no one
I
signs up?
suppose it could, but it's been struggling along for so long, I don't think that's going to
Okay,
happen.
so it doesn't mean you have a way out and not inform yourself. Inform yourself still, but just kind of observe what is happening right now.
They tried 41 times to.
They tried 21 times,
Yeah.
and Obama and White House has lined up their counter campaigns, so you're going to get bombarded
Right.
from them for the next 6 months. So that's the fun thing to look to. So since we're in Silicon Valley, maybe we can go to the employer side now. Is this healthcare law having an effect on hiring? Are people coming to you first wanting to see your package?
I have not seen a difference, a real visible difference, if I just look from that angle. From my seat and trying to pick the benefits plan this year, it's been interesting.
Would you like to share some more about it from your perspective?
Well, if I start first from the talent attraction side, right? Because that you're about to say we're in Silicon Valley, and what I've noticed we consider ourselves a small employer. The carriers consider us a small employer. But under this new ACA, we're considered a large employer. And I can see where the confusion is going to come in for our employees a little bit on this one. What I have tried very hard to do every year is I partner with my partner very closely on the employee messaging part to keep it simple, because benefits are so complicated. To really try to show employees, just even on a regular calendar year when we switch plans, what is changing and what's staying the same? What do you need to be concerned about and what do you not need to be concerned about? And then my team, and we do all of our benefits enrollment online, my team then has computers set up in their offices and sit and wait because everybody's going to come in and we end up doing them one-on-one. We're able to do that because we consider ourselves a small employer. What's going to be, and so last year there was already a couple changes. So increasing the age for students, for example, that was great news. People received that very well. That was an easy one, right? Reducing the FSA, the flexible spending account pre-tax contribution is not going to be as widely received and well received, and it was not. So there's going to be slight changes that, for an employer perspective, make it a little more interesting for us. And the perception we have to be careful about is that we're reducing benefits. Because in Silicon Valley, you do not want to be perceived as reducing your benefits. Not when we're hiring engineers and we're hiring finance people. We're competing against everybody. So this year is interesting because what's happening is I have an average workforce age of 46, a little bit above that. And we started off the calendar year, and my team and I looked at each other and thought there was an unlucky star over our employees because we had so many illnesses and some of the big names that you mentioned. So we had a lot of hits that in the back of my mind, that wasn't the foremost thing. It was getting our employees through all of this. And now that we're sitting down to do our benefits enrollment, our carrier is saying, you're not a good risk anymore. You had way too many people who were ill. And so what do we do with that? Well, they're going to raise our rates beyond any possible imagination of what anything we could keep. So now we have to go out to market, which what happens is your carrier is allowed to bid first, and then that becomes public knowledge, and then the other carriers try to outbid. Well, if your carrier goes too high, and they call you what's called an outlier, then the other carriers take their quotes right off the table, and you're stuck with the carrier you have at that high rate. So we were encountering this, and a lovely broker that I have, and I can only say wonderful things about brokers, so if you have your own business and you don't have a broker, get one. She called me up, and she's working behind the scenes, and she called me up to give me the advance warning, and what she's doing is she's negotiating our current carrier down to not call us an outlier, promising them that we will leave, and that way we'll be able to get alternative quotes. So that's the game behind the scenes, right? And I'm sitting there listening to this going, I'm so glad I have you, because I don't know that I would know to do that kind of thing.
Can I ask you, has that changed the dialogue between you and your employees? Because
Not yet. It will.
Not yet, because
It
it's
will.
almost, you know how when we're employees, we're thinking, oh, they're trying to screw us.
Yeah.
Well, it seems like they have to do a lot of jockeying and fact-finding to find the right thing where they will also win as an employer. And you will win as an employee, right? So it shifts. I think there's great opportunity to actually come to the table with your employees differently, right,
Well,
when they know.
The good news is, in one way it's good news. So last year we had an insurance premium hike. And we were very wide open and transparent about it, and we didn't pass it on to our employees. We absorbed all the costs because we knew we were going to have trouble attracting talent, again, if we raised the rates. This year, if we would have gone back to the 35% increase, which is what we were quoted, we would have had to spread the wealth. What I will be messaging this year is to tell people this is what happened with the other carrier. They're not going to be happy we're switching carriers because we will have to. That means their network's changed. The carrier that we were going to stay with this year and the carrier we wanted to stay with the year before both did away with our health plans that we currently had, so our health deductibles were going to go up anyway. Our out-of-pocket maximums were going to go up anyway. So this is the small employer world of, your negotiation power is not that strong, so you do the best you can, and you find the brokers that have experience in this, right? Or maybe can group you. She's looking pained over here.
Small groups don't have to deal with them at all. Have not had to since I think 92 or something, because they just get a maximum of 10% plus or minus.
Yeah, and that's what we're looking at. So the alternatives are going to be interesting in the next couple of years.
So some of you raised earlier your hands. You're covered by an employer. So have you received any notifications of changes coming down the pipe? Who has received any change notifications from their employer yet? None? Ms. Michele?
No, I did.
Oh, you did?
Yeah.
You did? Oh, interesting. Okay, nobody would think you would get one. Okay, so what
Yeah,
happened?
I mean, it's required by law that any employer send the information out to all their employees.
Right.
Okay, but you have not received any?
No one's received it.
Ours comes in October.
In October,
Yeah.
oh,
In
so we're
October.
early, yes, you're right, because we're in September, so that might still count, but now you are bracing yourself, you have
I
information?
think it was due by October 1st.
Yeah,
So we were
yeah,
told that all of
Mama
this,
knows. Okay.
you
So
can't
it should
wait.
be
It's
coming
not,
any
it's
moment.
not tied to your re-enrollment period, it's just that you're required, all employers who offer their employees insurance are required to tell their employees about.
So maybe I can segue in, you said pre-existing conditions, chronic diseases, you were not such a good lineup. Are you toying with wellness or preventive programs that you're offering or encouraging your employees? And maybe, Michele, then we can follow up with you where you can share your experience about what you are doing in that space.
In wellness.
Wellness program with employees. So let's start with,
So the wellness side of it, it's interesting, and so my broker, again, I'm gonna sound like she's my guru. She and I kind of sync up on the idea that we're concerned about some of the privacy around people being in some of the wellness programs that are the pre-designed wellness programs. So we're trying to, things like smoking cessation, for example. I worked for one employer where they had that. And you start getting into people's lives a little bit more while you're trying to incentivize them to stop a behavior that maybe they shouldn't be doing. So our philosophy at our employee base has been to focus on education. So we bring in a lot of the brown bag seminars. We added the employee assistance plan a couple years ago. We've put Zumba classes on site. We've brought in a Zumba instructor. So we have all kinds of people doing classes on site right now. We did a contest where people get a little Fitbit they would win a little Fitbit to wear on their belt if they logged a certain number of hours of any kind of exercise. So we try to do things sort of where we don't get into people's lives too much, but we're nudging them and have some healthy behaviors.
Michele.
So we do many of those same things. We just started recently an employee wellness campaign because what we're trying to do is improve the overall wellness of our own employee base, because as a hospital, our motto is the hospital that keeps you well. So we want to make sure that we're sort of practicing what we preach. So we want to start with our own population. And I don't know if you're aware, but healthcare providers and healthcare givers aren't necessarily healthy. So they don't necessarily take good care of themselves, which most women actually don't take very good care of themselves. We're busy taking care of our families. And in a hospital environment, it's usually about 85% of our population is female. So nurses, all the different care providers. So we've started a campaign, and we incentivize our employees. So we had sort of three $50 campaigns. One was that everyone had to go and get your sort of basic, cholesterol screening, blood pressure, all of those things. So if you did that and you knew what all your scores were, you got a $50 gift certificate. We then went to another structure where we had little computerized, games and quizzes and different things that you would do. And we bought it from an outside company, and if you participated and you were part of a team and you got to a certain number of points, you would get $50, and then if you continued on for more than 4 months, that you would do. But we also offer, and part of it is because we're a hospital, we offer a whole wealth of different health education opportunities, smoking cessation. It's both for our patient population as well as our employee population.
And did you also create wellness programs where employers that live right next door to you are coming to you saying, hey, can we use your facilities to teach our employees? So have you done?
We've gone out and done, we have Speakers Bureau, and we go out and do lunchtime speaking things. What we want to do with our whole wellness campaign is make sure that we have it down and we show some results. So in the next 3 months, we're actually going to go back out to our employees and retest them and see if we did have an impact on all of these things with blood pressure, cholesterol levels, those kinds of things. So we want to make sure that we have sort of evidence-based that what we did with our employee population and then replicate that out to the employer population.
Yeah, because all of you know Kaiser, and Kaiser has been very outspoken about all of their achievements, and they also always have press releases on their achievements after a year where they test and retest, and yeah, it has gone down by 50%, and then they templatize it, and then they sell that to employers. And Safeway is also in the business of that. Sure. It's a huge business for them. So that's, since you said earlier that we might get more patients because more people are getting insured. Your margins get less.
Yes. So do
Because-
you want me to go in to that?
Yes, please, because, you know,
Well,
we
one
just.
little thing I wanted to point out is that is our MRI machine, and that means we
Yeah,
have
yeah.
an emergency room patient.
Oh,
And
wow.
not all of our emergency room patients
Our
are
prayers are with that person.
Are insured,
Okay.
so this is a real life example of someone who's up there who could or could not have
insurance, but because of the Teslas and all of those kinds of things, you hear the vibration. But don't worry, we're diagnosing them, so we're helping them out. So just a few things in regards to hospitals, and I'll just focus on hospitals because Kaiser is a different kind of.
That's an
it's a-
integrated system.
Yes,
yeah.
an integrated, so it has the insurance, it, employs its doctors, and it has hospital services too. So we don't employ physicians, so they're all independent practitioners. But we have the hospital, and then we get paid by insurers, whatever we hopefully get from them is what we get. So overall in California, over the next 10 years, it's anticipated with this new legislation and with the aging of our community, that hospitals are going to lose about $22 billion in revenues, primarily because of Medicare and also the Affordable Care Act. But I think if you talk to any hospital or any provider, we're all very much pleased that we'll have more and more of our citizens that were actually insured, because we do see them on the front line of folks who come to our emergency rooms who aren't insured, or they have no money, and so we provide a lot of charity care here as well. So there's sort of a double-edged sword. And does everyone realize that the Medicare and Medicaid are the government programs, Medi-Cal here in California, and hospitals and providers in general lose money on both Medicare and Medicaid patients. And so there's been a lot of cost shifting over the years to those of us who have PPOs, HMOs, who are the non-government insurers. And so what we've been doing is sort of keeping our margins okay at 2% is the overall average for California hospitals. So as you know, that doesn't really pay for our 3 or 4% increases for our salaries, but that's kind of where we are. But the anticipation is that we think that some of the people who currently get their insurance for companies that are small, with 100 or less, will actually shift to the exchanges. And under the exchanges, hospitals in general will get a lot less money. They'll be paid more similar to what we get from Medicare and Medicaid. So the profitability of hospitals today is about 80%, make on average about 2% as far as the bottom line. And it's anticipated that over the next 5 years that 75% of the hospitals will lose money in California because of the shifting, the cost shifting that's going on. So we take the 2% of where we are right now, and we'll have more people that will have insurance, and we'll actually see about a 1.2% increase from that. However, when we see actually the aging of our population in California and the shifting of some of the people that were in PPOs and the commercial insurance to the health exchanges, that's about a 1.5. So now we're about even to where we were before. But then with the new payment methodologies, and as you saw in the little comic there, that where are they going to get the money to pay for this? And they said hospitals.
Someone has to pay.
And so someone has to pay, and so it is going to be hospitals. And so we anticipate that overall our margins are going to decrease by 10% just of that new kind of payment methodology. So the new margin for hospitals will be a negative 8.5% in California.
Okay, so we're going to see hospital consolidation.
We might see that, and I looked into what our hospital here, so we're much smaller than some of these big systems. We're an independent hospital. Last year in 2012, we provided $32 million in charity care, and overall community benefit. 3.2 million was in charity care with people who have no insurance, and then our unreimbursed Medi-Cal. What we do is we look at the service, the cost of the service that we provide to the Medi-Cal patients versus what Medi-Cal, the state, pays to us, and that was about 13 million. So we look at all of these new exchanges that are coming in, they're going to be paid at much lower rates. We're going to be having a challenge. So we're instituting a lot of new things here. Many of you are probably familiar with the Lean methodology. And so we're implementing that now in hospitals and really trying to become lean.
What is that? Can you?
Well,
what we're trying to do is become more efficient. So we're looking at very
Okay.
detailed at all of our processes and try and take more and more waste out of the system. And so those type of things kind of.
You meant lean isn't slimming down. I thought it was
L-E.
L-E-A-N and it stood for something
No,
complicated.
It's just the overall, trying to become
like
much more
losing weight. Yes,
efficient.
being more efficient.
Yes.
It's
So
a
we're
quality
trying- it is a
application
quality
that came out of
application.
technology.
Yeah.
Or you can
So
say
we're-
leveraging effective application.
Yeah.
Well, there you go.
Something like that. Okay,
So, and overall, in what we're thinking, then uninsured population, I don't know if you quoted that, it looks like it's about 480,000 folks in the Bay Area. So
I didn't go down to the Bay Area level.
So
but
the Bay Area is about 480,000 and about 100,000 in this county, in Santa Clara County, and about 100,000 in Alameda County, and then smaller.
So think about it, if their profit margins are getting shaved, we're gonna look at more closures of hospitals, potentially, right? So wouldn't that open up an avenue to have more dialogue around the elephant in the room? And I mean, I alluded in the beginning where there was a survey of what states in the US are actually getting a grade when it comes to being transparent about the healthcare pricing. And Massachusetts and New Hampshire actually had the only state that earned an A in healthcare pricing, while 29 states earned an F. We got a D. It's not that great. But what was interesting, there was also another survey where they said, patients don't want to deal with the price. And you know what? They also have a perception that if it's cheaper, it's probably not as good. So what do they go for, and what do most physicians apply is maybe a more expensive, but then also there's a liability issue. We want to make sure we don't get sued. So that comes in addition to that. So wouldn't it be great to start having a conversation with your patient where a physician sets the patient down or an employer sets the employee down? This costs money. Here are your options. We're willing to pay this and that. I think, we as parents sit down our kids when we're trying to explain, if you do this, it's going to have this impact and it's going to cost you later. You can have instant gratification, or you can kind of, sorry.
Excuse me.
And
I
so
have a
what
related
I-
question.
So I'm curious about the forced pricing, however. There's some large corporations
Well,
that
hang on, let me just
conveniently,
finish the thought, then we do force.
Yeah.
Okay, so conversation between physicians, employers, employees, or physicians and patients. Where is that going? Do you see a trend towards having an honest discussion around the elephant in the room? How much is this going to cost?
Well, we have more and more patients that now call in advance, especially for things that, are not emergencies and are sort of more predictable. So things like mammographies, women go in hopefully every year after you're 40. And if it's a screening mammography, it's a fairly standard procedure. And so we have like a cash price for that. We can tell you exactly how much that's going to cost. Even for maternity care, we now have a set cash price. Or if you have a vaginal delivery, and we have a different price if it's a C-section. But we have to have all of these caveats because you have to have a signed off by your physician that in fact you're healthy enough and that you will not have, some circumstance that we all don't know about, and that your baby will have other problems that, need to have special coverage. And so, you have to sort of say, okay, well, you can only have this, and in order to do it, because people think that there's just one price, but we have no idea of the health of people. So you could be a mom that has high blood pressure, and you're on all kinds of medicines, and
it becomes an
your
emergency
delivery
when you're delivering,
might not be, just sort of textbook. So it's difficult, I think, in the healthcare industry, and I know we probably got a D because we can't necessarily tell you exactly what your cost is going to be, because we don't exactly always know what we have to do. Even in the case of mammography, you could come in, and it could be that you have, some kind of discovery of a lump or something like that. Then you have to come in for another mammography, which is called a diagnostic, which is much more extensive, and we have no idea how long that's going to take or what we're going to discover from that, and then it sort of goes on from there. So it's difficult to tell. I mean, we're not robots, we're all individuals, and we all have our own individual health needs, and so it's difficult for us to really determine what it is. Not that that's an excuse, but it's just harder.
Do you see more conversation going in the direction of actually looking at price related to?
Oh, yeah.
I would
Sort of
actually
a
welcome that
baseline.
very much.
Yeah.
Yeah, I would very much welcome that. And I think, with some of the carriers, they actually do give you a general idea. You can go to their website, you can type in what's the procedure code or what service you think you're gonna need, and they'll give you a ballpark figure. So there is some of that out there. The transparency on pricing, I think, is really important. The issue, though, that I'll always come back to is, and I'm someone who deals with benefits, and you said, oh, the website's great, it's got everything on it. I looked at that website a few times, and even with my base of knowledge, I thought, oh, I gotta wait till I have a cup of coffee, and I need to really have some mind space and time to really focus on this and read through everything and process it. So, the stereotypical person is still gonna need some help. They're gonna need some help to navigate all of this.
Oh,
They're
absolutely.
gonna navigate the pricing and the hospital,
Sure,
and
yeah.
all of this. It's, so, going to multiple seminars, I think, is probably a really good idea.
So we had Forrest in the back, and then you have your question. So what was the Forrest one?
Well, I conveniently forgot about the name of the corporation, but sending their employees through an evaluation on blood pressure and so on, and then basing their coverage on those results. And I think that's a little bit tough for people to consume, based on the
Oh, so you mean you're
invasive
forced by your employer to do
to-
certain things in order for
Exactly.
your employer to
Yeah.
assess? Okay.
That doesn't
That's
work.
not legal.
well,
There are legal parameters around this, right?
Yeah, I
For-
think so,
depends on the state maybe, but again, I
Okay,
forgotten about
well, but
the
I'm hoping, this is also maybe to shift your mindset a little bit. So it's not just, the darn employer is making me do this. I mean, you heard the employer perspective. It feels more like the conversation and mind shift should be more collaborative, right? That's sort of, okay, you had a question in the front.
So my question is I heard some horror stories from a friend that it cost him $10,000 because he was uninsured for a colonoscopy. And then going through that MRI where you lay down and you go through it cost $20,000 for his mother. So I was looking at the Obamacare, and they tell you there's a bronze for 60% coverage all the way to platinum, which I don't know if it's 90% or 100%. But I was wondering, what has been the employer's approach in the past, and what do they offer? Do they offer 80% coverage or 90% coverage? If there's any kind
That
of
varies
history.
from employer to
varies.
employer, right?
No standard, huh?
Well, 90%'s pretty darn rich. I don't deal in the Silicon Valley as much, so I don't know how. I have some clients that are, and they tend to go at the 80% level. But for my non-Silicon Valley clients, 70 to 80.
Oh,
That's about it.
interesting.
Yeah.
And, unfortunately, I have to put a wrinkle into that conversation because you think if you're covered by an employer, you're all fine. But here's what's going to happen in 2018, right? There's going to be another shift, and then it's the Cadillac tax, and guess what? There was actually a survey recently. 92% of all employers says they're going to revisit their plan that they're offering by 2018. So if you don't deal with it now, you're just kind of pushing it further along, kicking the can down the road. I think this is a good time to actually embrace the care, have a cup of coffee, have two, and maybe deal with it. Start with Covered California. I think videos like the one we saw, it takes away the fear, and that was the intention. The video came through, I have resources it's content created for journalists by journalists in order to help journalists to better report these issues and more meaningful to a wider audience. And it's the Kaiser Foundation is one, there is healthinformation.org, there is Michelle Lavender. I can send you all those links, and I think they're also cited in the primer.
You have a question?
There's a question.
Yeah. Oh, sorry.
Yeah.
Barb!
Yeah.
The one who made it happen. That's why we're
Me?
here.
No.
Yeah. That's why we're
Not
here.
at all. Glad to be a part, but I didn't make it happen. That's Nicole right there. But anyway, question on things that you just said. Couple of things. One, the 70-80% coverage. Does that take into account the deductibles that people are, the higher deductibles, and is Obamacare going to change that at all? I know now a lot of employers are moving to the sort of healthcare
Health
savings
savings accounts
model
kind of
where
thing,
you have
yeah.
a huge $10,000 deductible up front.
Well,
And then I have a quick follow-up question before I forget it. Sorry, my mind's like a sieve.
right.
The second, your El Camino's, what I think must be relatively innovative fixed price model. Is that in response to Obamacare, and are you innovative? Because I haven't seen hospitals that will give you here's a ballpark. Granted, there's a million contingencies that could
could change that, but at least, you know, coming in, if you don't got this much in savings, you better start saving in those 9 months before your baby gets here. Are you innovative there? Is that normal in California? Because
I think most of us in the Silicon Valley have a fixed price.
you do.
So I
Is
think
that
we're
the
all
Silicon
responding
Valley?
to each other.
Yeah, okay.
I think a lot of it also, we have a unique population. We have folks that fly over and, at least in the baby business, to have their babies in the US.
Really? Fly over from
Yeah, it's
Usually the
medical,
Far
it's called
East.
medical tourism, right?
That went the other way.
Well, we have a big flux of people from outside the nation that come.
Because your care's so great.
I don't know, I think, you know, I would like to say that, yes, we do provide great care. I also think that there's probably a citizenship issue, but that's a whole
Okay.
different
Oh, right,
issue.
okay.
Yeah, they have it
Because
here
once
and
their
they come
child
here.
is born here, they're American.
Absolutely, okay,
That's
interesting.
interesting.
Thank
But we have to care for them because they're here.
Right. But the first question then
Yeah,
about
the
the
first
78.
question, it does incorporate that. Usually those high deductible plans, which aren't quite as popular as they were because the costing for them has grown quite a bit over the years. So it's not as cost effective to have a high deductible plan where the employer has to make up a lot of the difference than it is to have a lower deductible plan. It's just, it's not cost effective as it used to be.
The ones I know about, the employer doesn't make up the difference. It's up to you to cover the 10 grand, and they'll cover whatever past that 10 grand, you get 70 or 80% after that.
I would say that's not a 70 or 80% plan. I'd say that might not even be a 60% plan. I have no clients with a $10,000 deductible.
They're brutal.
Yeah,
My
that's brutal.
sisters in the Midwest all have them, and they work for hospitals out there.
That's brutal.
Yeah, it is brutal.
Yeah.
And
Okay, so that would
is
actually
that
beg-
affected by Obamacare?
What?
Is that affected?
Yes, because of the Obamacare requires certain levels of actuarial value, the lowest being 60%, which is roughly a $4,000 deductible at the most.
See, I thought that they had some loophole where they didn't count the deductible.
There's ways to, you have the same actuarial value as a $4,000 deductible. Some of them are going higher by tweaking it in other ways,
Okay,
but
good,
nobody's at 10,000.
great.
Stephanie.
Thank you.
There, yep. Go ahead.
What does it mean that Aetna leaves California, so everybody who's insured with Aetna is
Aetna has
left?
decided not to participate in individual plans in California. They're still writing group business, they're still writing Medicare business, but they're not making any money on individuals. United Healthcare is also not writing individual coverage. So they've decided to let the carriers that, the few carriers that are left do it. And those carriers are Health Net, Blue Cross Blue Shield, and Kaiser, pretty much.
Stephanie.
Yeah, it was also about the percentage of what is covered and stuff. In my dental plan, I just realized that I thought I was very, you know, I was lucky with my 80% coverage or whatever it is, but it's based on, for filling, my daughter needed filling. It's based on it's called
A fee get maximum allowable charge.
amalgam, this old stuff that people.
Not the white fillings, yeah.
It's and the dentist said we don't put amalgam in your mouth or in your daughter's mouth. We would, you know, that's
Dentists
really
never do
poisonous.
white. Dentists always use white fillings.
But then there's no such thing as 80% because, you know,
Right.
they base it on some, and that's my question is, you know, what is it always based on these 80%?
Well, dental is different than medical.
Oh, all right, okay.
There's a loophole.
Definitely a loophole. I'm shocked.
And on the medical side, you're hopefully going with usual and customary, which means what what most providers do in the given zip code for that given procedure. So you're not terribly concerned or you're not terribly frightened when you get your bill because it's reasonably covered. Also, all health plans have a maximum out of pocket, so that's the worst that's going to be for you for that year. What's something's interesting with the ACA plans is that out of pocket's kind of high. It's $6,350 unless you go for the platinum plan, and that's higher than most plans are. So it's not necessarily that you're going to get better plans with the new ACA plans. They're going to include more, but you're still going to be potentially out of pocket more.
So for those who are very young and saying, hey, I don't need health care, so it's going to cost you only $95, you know.
That's
and
true.
That's your
To
tax
beg
penalty
off.
now. Then it goes up to $695
Yeah, 2
in
years.
2015 or 2%, whatever's higher. So, there are ways of getting around it. I just wouldn't recommend it for those events. Also, I have a whole list of health plans, the various types. Short description, it's in the 18-page primer. It was put together, I think she's in her LinkedIn group. You will know her. She's a very prolific, amazing consultant. She's listed all of the plans are in there with a quick description and caveats. She gives it to you straight because she's a patient advocate. So I would say take a look at that one too, and you can actually go to her website, sign up for her mailing list, and get additional information, because that's all the stuff I get. So I put it all in and got all your resources. So, okay, we've decided we're not going to forego a health plan, and we're not going to do penalty. I have much more here. There's also COBRAs in here for you if you want it. It's on page 12. IRS doesn't have much teeth when it comes to reinforcement. They can see how much you're making, but they don't really have reinforcement teeth to go after you. But know that somebody knows and the government knows how much you're making in what year and if you are having any insurance. I think I'm sort of, we've discussed everything, and I'm open to questions from the floor. I have more, but I think it's more important that you guys get your answers. Go ahead.
I'm hogging the questions here, sorry. I just listened to, y'all listen to public radio, hopefully. Michael Krasny had a great thing on the other day about the trouble. One of the problems that's coming around the bend as people get older is that we're having an increase, we already have one, shortage of doctors and nurses assistants and physicians assistants and everything. And
because most physicians left and went to a hospital because it's safe.
Well, no, counting the physicians who left and went to the hospital, but they were toying. This talk was about allowing foreign trained doctors to practice in here and recognizing their certification. But my question as it applies to Obamacare then is what outside factors are playing into your profit margins being so slim? Does it all get back to Obamacare? And if not, are there other ways that we can fix it? In other words, get more physicians? They said the problem, non-foreign trained, is the lack of residency opportunities. There's, for every residency opportunity, there's 10 applicants, and only one gets it. And those other 9 don't get one. So there are doctors who are through the university training but can't get the residency practical training, so they just cool their heels. Are there other, that was a long-winded question.
So
of
we
saying,
don't
are there
employ
other
physicians, so we don't pay them, so that wouldn't be one
It
of our
wouldn't
cost
affect your-
factors.
yeah.
But certainly the aging of the population is because as we age, we get more chronic diseases, and so then we're hospitalized more often and we stay in the hospital longer because you have lots of different comorbidities of the reason why you're sick, and so then we get paid by Medicare based on a diagnosis. And so we only get paid for X number of days, and X drugs and all those kinds of things. And so if you have a more chronic patient, they're probably going to have to stay longer than that. And so the chronic disease actually inflates the overall cost, just because as people are more acutely ill, we have to do more things and take care of them. So.
See, as a non-physician, as just a business person, it would seem to me that more demand would equal higher profits. Why is it that having to do more services doesn't equal?
Because Medicare just pays us X
Because you have a
amount.
maximum
So
no matter
if you
what.
have a heart attack, we get X number of dollars.
Okay.
So if it costs us more than that to
Then you
care
eat
for
it.
you, because maybe you also have diabetes and maybe you have all these other things, we only get paid for that one diagnosis.
And does Obamacare make you eat it, or you just do because you're a good institution?
The government, so this is Medicare, so
Right.
this is not Obamacare.
Okay, right.
This
I
is
keep
not the
doing that,
Affordable Care Act.
Yeah.
So we have government insurers like Medi-Cal and Medicare, and then many of the Affordable Care Act, some of those insurers will be paying us about the same as Medicare rates.
Okay.
So we're not doing well under Medicare or Medi-Cal right now, and so if we shift from commercial to more of the government paid, then we'll have trouble, because in fact we just get set amounts.
Right.
And so that's why we have to become more efficient with the care that we provide.
So other than Medicare, are there any other ways? I mean, fixing Medicare, which is a whole different kettle of fish in itself, but are there any other any outside factors that would affect your profit margins? In other words, getting more physicians in or?
Well, getting more physicians doesn't really do anything
It won't.
different for a hospital like us, because they're independent practitioners, they practice here, but we don't pay
Right.
them. So the more physicians you have doesn't necessarily increase our costs.
Right.
Because they bill to you, to the patient directly, right? And they also get paid. The one thing that we're seeing in this community, and probably a lot in the Bay Area, is that there's fewer and fewer physicians that will accept Medicare or will accept Medi-Cal. And I know you spoke about smaller networks. A lot of that has to do with the fact that they're not getting paid.
Just stepping out,
Yeah.
Physicians.
So physicians are saying, I just can't make it
Yeah.
with the amount of money that you give.
Yeah.
So, so you're seeing, especially as with the baby boomers aging, there's fewer and fewer physicians that are accepting Medicare as payment. And so that will cause issues for us to even get care.
Right.
So it could be that we look at physician assistants and other kinds of care providers that maybe work in conjunction with the physician, but you're not always going to see the physician. Perhaps you'll see the physician assistant or nurse practitioner. I know Kaiser uses some of that model, and these other ideas like group visits where you have one physician and then you have like 5. So all of those are sort of seen as efficiency to try and deal with the lower payments that we're getting from the government.
It gives a new meaning to communicable disease.
Well, you wouldn't do that for the ones who are infectious diseases. You put them all in there. You probably do a conference call with them. or
Well,
something
you know,
like
and that explains why Michelle Obama has been on the bandwagon for eating better, for now drinking. Because, I mean, look at these numbers. We said it costs $8,500 per person per year. Of those 85, around 6,100 go towards cancer, heart disease, diabetes, and chronic. Jesus, it's all preventable. So that's why people need to be taught, and kids need to be taught, to eat better and drink better. And I think that's why Michelle Obama is coming from the other side. They're getting it. It's just the system is crazy. So do you, for example, go to Europe and take a look at a Danish system? They always hold out the Danes. So Danes have, what, 5 million people? It's a very small homogeneous group, and everything works there. It doesn't work here. And I always think, well, you can't apply it to 300 million completely different people from different tribes arriving here at different innings, and it doesn't work. Are there any examples from abroad where you feel like, Michelle, we should adopt this? Have you?
I haven't, I mean, there's certainly literature out there,
Yeah.
but, you know, the British health system is looked at, but I know a lot of folks in the US, at least on the provider side, don't think that that's the right model, and then there's now, you know, for-profit entities that are there to just sort of take up the slack of folks who don't want to use the British health system, but I know that there's a variety of systems out there that work at least more efficiently than we do. Some of the people say that the difference between some of these other countries is that in the United States we like to have choice. So we like to decide, right? I mean, sometimes your doctor says, well, you could do this or you could do that, and then you say, well, I want to just make sure I cover all my bases, so I'm going to go in and I want, you know, the full diagnostic workup or whatever. And so it's I think for Americans, a lot of that is the right to choose. And so we want the best, we want the latest equipment, we want to do all of those kinds of things. And in other countries, as I understand it, and I'm not well versed in all of them, they just are offered, you know, X, and you have to live with that, or you have to wait 3 months before you get your MRI, and those kinds of things, as opposed to many of us want it today and right now. So I think it's just a little bit of a different culture and what our expectations are of healthcare. I mean, what do you all think? Do you think that's true?
In Germany, I remember when I was there the first 20 years of my life, when I went to a doctor, I trusted the counsel. Here, I question because I wonder, are you saying that because you're scared you're going to be sued? And then am I doing this test because that way you cover your butt? Do we really need it? Because of those 2.7, the number is $810 billion that are going towards wasted, duplicate procedures, yada, yada. So when I was in Germany, I always felt like I got the true physician's counsel. Here, I feel like I'm getting a physician counsel informed by his liability insurance, by the insurance he has to deal with. I never feel like I'm really getting the real physician, except there are, of course, human exceptions where the physician, he just speaks off the cuff and he gives it to you. I don't know if that experience is relatable. Is that what your take of that is? Barb, you're giving me a...
I'm giving you, I'm
You gave me the
big
evil eye.
mouthy over here, sorry, but I lived in Germany for, I don't know, five-ish years around, off and on. And what I was struck to the difference, and my family's in medicine, hence my big mouth and interest in this, but what I was struck to the difference was, say there was a drug that was exactly right on for what you had, but the doctor only had a certain allotment of that drug to prescribe. And if he was reaching his allotment or she was reaching to a certain level and it was still 3/4 of the year to go, well then they're not going to offer it to you. And the same was said of tests and treatments. They had a certain bank that they could use, and they rationed it across, and it's not healthcare rationing necessarily as we think of as Americans, but they definitely had that in mind. So I think the devil's advocate perspective would be, okay, here maybe we go overboard in prescribing the most possible tests because we want to be the most possible thorough, which may be a bit wasteful. But I think my perspective, at least as an American living over there, was it was a bit the other way. They rationed based on their allotment in their bank.
And that could be a debate. I think we're getting close to the finish. So here's the last question. I'm hoping that I'm echoing what you might want to know. So they all go home. What should they do? What should they do? Should they jump on Cover California? Should they call Lynn? Hopefully never see you, Michele, because that means they're sick.
No, they'll take care of you, regardless if you have insurance.
Okay,
They'll want you to have insurance.
Please give me each your answer, what your recommendation is to this audience.
I'd say for those of you that have a group plan, just stick with your group plan. And hopefully your employers are being thoughtful about what they're doing with that. Our group clients are mostly renewing early in December so they can sit out this next year and not worry about it. And then adopt Obamacare at the end of next year. If you have an individual plan, you're going to basically be losing them as of January 1st anyway. So you need to assess what's out there because all of the individual markets are switching over to an ACA compliant plan, and you have an opportunity to switch to something that's good. So get some advice, or explore it, or find a broker or around, and we'll help you through that. If you're in a particular situation like your COBRA, check your options. Because if you don't enroll now, you have to wait until the next open enrollment, which is at the end of next year.
Yeah, I think I'm going to just make the transition personally to Obamacare because I don't want to have my insurance keep changing every time my job does.
Yeah.
It's a hassle.
So, can you comment on, I have an individual plan that is grandfathered because
Then
I
you
got it
can
for a
keep
month.
it.
And I can keep it, but then, do I need to be concerned about it not the good provisions, I would call, of the ACA?
Yeah.
I'll take a risk that maybe, my rates are going to go way up.
Your grandfather plans do go up higher, and you do lose some of the good provisions of the ACA. So you should do an analysis, or have somebody do an analysis for you.
But I like my plan, but I will do the research.
And it may be fine, it may be fine, right, yes.
So my question is, I know a couple of friends of mine are not insured at the moment at all because they are self-employed and maybe on the edge to being considered poor, but not poor enough for Medicare, Medicaid. So my question is, what exactly can I tell them what they should do?
They should, if they don't want to use a broker, they can go onto the Covered California website. They can key in, there's a calculator in there, and they can key in their income. And it's not just their historical income, it's what they expect to make in 2014. Because that's what's going to happen at the end of 2014 is you have to justify what you made compared to the subsidy. And it'll tell you what your subsidy is and how much you have to pay for your different insurances and your different for your different carriers and the different plans. Just a word of caution, and I gotta say this quickly, the networks are being made thinner. You've gotta be really careful. For example, Anthem Blue Cross in Alameda County and San Francisco does not have the Sutter system. That's basically Alameda County and San Francisco. So it would be irresponsible to go with Anthem Blue Cross. So you're stuck with either Kaiser or a Blue Shield EPO, which means that an EPO means it's an exclusive provider option, and you can only use Blue Shield. You can't go outside of the network. But it's still going to be a better option than Anthem in those counties. So it's your choices. You've got everything is available to you, but look carefully because a lot of times nothing's available to you. So you have to review it carefully. And I got to tell you, a lot of this information isn't available yet. I still don't know I do not know the provider lists. And you've got to be really careful making your decision to check to see if your doctors are on the list.
Will it be available before?
Yeah, it'll be available before you have to commit. But it might not be available October 1.
Yeah.
But you still would say it's a good idea to use a broker, right?
I always think that's a good idea.
Yeah, and also the calculator is linked in that primer, so all the links are in it, so you can literally just click your way through it.
All right.
Just FYI. And also, all their profiles are on there. I didn't put your emails in it.
Okay.
Just one last question. I was not quite sure if this relates to the grandfathering. I'm a member of Kaiser, and when they tell me my current plan, it stays. I'm still insured with them if I don't want to change it. So this means the grandfathering in, or
If your plan's not going to change, then it's grandfathered.
oh, okay.
But you may not know yet.
Okay, thank you.
On the show, it showed for small businesses less than 50.
Yes.
It's not changing until 2014 or 15.
What they're talking about is businesses over 50. That for businesses over 50, there's a mandate that you either insure your people or you pay a tax, basically, or a penalty.
So if you have 49.
At 49, you're considered a small group.
Okay.
And you don't have to have insurance at all for a small group, but there's a lot of reasons why you do have insurance.
And also, by the way, we didn't talk about it. There's also it's called SHOP.
The shop, yeah.
Right, so it's also in your link, that is for small businesses. It's another area under the covered California. So look for SHOP, and that's for small business owners that have several employees. It's linked in the primary.
That's a good vehicle if you want to combine Kaiser with another carrier.
Where's the list of the accredited brokers?
It's also on the website,
on the
it's in there,
website.
and there's a link that says Find a Pro. I put the link underneath that.
With the grandfathered plan, does the 46,000 as an earning, does that kick in there too?
No. You can't. If you keep your plan, you don't go onto the exchange at all. You just keep your plan. So if you have low income, it's worth it to go look at the exchange. Yeah.
So I would make a decision to an individual plan or setting up a small group plan for my company. And do you think that there are way more options and better plans in the group versus the individual with your Obamacare?
Because the group plans are going to look a whole lot like the individual plans. They really are. Consider carefully whether you're going to set up. There are reasons to set up group plans other than the cost, but you don't have to. But what you can't do is you cannot pay your employees to go buy plans on the exchange. You either you either have no plan or you have a plan. So you have to be a little careful about that.
Okay, so that's my realm, so I can talk a little bit about
Go
that.
ahead.
So I used to consult for about 11 years and helping small businesses figure it out. Going into what we're going into right now, you're trying to stay competitive.